Next is PE-LIF approach. These approaches are for regular T-LIF, PSLD-LIF, and UBE-LIF. SAP must be cut off. The spinal canal must be invaded, so dural damages tend to be occurred. These are X-LIF, O-LIF, and A-LIF approach, of which the good points are no canal invasion, posterior muscles preserved. However, these methods have risks of damaging the intestine, ureters, and vessels. ME-LIF approach is from more lateral than T-LIF. This approach is similar to the transforaminal method. The opposite side incision is only to insert sextant pedicle screw. It needs decompression of lateral side of SAP and total discectomy. The spinal canal is not invaded. However, not under continuous water irrigation, endoscopic view is not so clear. The other original approach, PE-LIF, is similar to ME-LIF. PE-LIF needs unilateral decompression at Kambin's safety triangle, like Percutaneous endoscopic discectomy. It needs no bone dissection, no muscle retraction, and no canal decompression, so no dural damages and no internal organs damages. PE-LIF is clear vision under continuous water. IT Spine Hospital developed PE-LIF is performed using a full endoscopic conventionally used for discectomy. Firstly, start by harvesting cancellous bone chips from the iliac crest using a trephine via an 8 mm incision. Total transforaminal discectomy is easily performed through safety Kambin triangle. The unilateral approach is used to sufficiently remove the nucleus and Endplate using the outer sheath cutter. One cage is transmitted into the intervertebral space along the special designed L-shaped retractor slider. In case of a highly instability such as spondylolysis or spondylolisthesis, it should be fixed using stable pedicle screws. 4 incisions are 1 centimeter, and 1 incision is 5 millimeter, which are minimally invasive operations for the patient. How to harvest the cancellous bone chips? Firstly, set the image intensifier 30 degrees to the head side and 30 degrees to the opposite side, and project the teardrop image on the monitor. A gem CD needle is inserted to the iliac crest. A needle aspirates bone marrow blood. Collect the cancellous bone chips from the iliac crest using a trephine via an 8 mm incision. Okay. Push out the bone chips from the trephine onto the Petri dish. Forceps is also useful to collect the bone chips. Mix the cancellous bone and bone substitute such as hydroxyapatite, collagen hybrid, and calcium phosphate. Mixed bone chips are packed into a cage. A, total discectomy and endplate resection through Kambin's safety triangle. B, in the unilateral approach, the endoscope is inserted to the disc space, red circle, at 45 degrees. And then the endoscope can be tilted widely from 30 degrees to 70 degrees to create a wide range of the mother bed yellow circle. However, in L5S1, its range of motion is limited, so bilateral approaches are required. If there is foraminal stenosis, foraminotomy has to be done to prevent the exiting damage during the insertion of a cage. Or there is a radiculopathy due to lateral recess stenosis or herniation, ventral fastectomy is necessary. It is important to rationally remove the entire disc and end plate. The outer sheath cutter has been improved based on the duckbill outer sheath. Its tip is wedge-shaped at 45 degrees. Rotating the cross handle is effective for scraping the end plate thinly and aggressively. The scraped end plate and nucleus are then removed with forceps. The endoscope can be tilted widely from 30 degrees to 70 degrees to create a wide mother bed. The compression maneuver is performed from one side with wide foramen or radiculopathy to the other side, and from posterior to another. Let's show the resection area on CT. Insert outer sheath cutter from the posterior lateral and perform discectomy and endplate resection of the ipsilateral. Then tilt the endoscope horizontally to decompress the contralateral and dorsal side. Wide range of discectomy and endplate resection can be performed by tilting the endoscope appropriately. At L5S1, ROM of the endoscope is limited, so bilateral approach must be performed. Finally, the expandable blade cutter is inserted with the tip closed, and then the expanded tip can smooth any remaining irregularity on the end plate. The flexible curettage can also remove residual cartilage tissue. As a result, a smooth mother bed can be created with continuous water irrigation and a full endoscope. How to insert the cage. This figure shows the relationship between the cage insertion pathway and the exiting route. First, the intervertebral disc space, Kambin triangle, is decompressed to make it easier to insert the cage. L-shaped retractor slider is inserted into an 8 mm outer tube. Round corner of the L-shaped retractor slider protects exiting route. The holder with the barrette cage filled with the substitute bone is sandwiched between double L-shaped retractor sliders, allowing easy passage through the skin. Immediately after the tip of the barrette cage reaches the disc space, remove the caudal retractor and advance in the cage to 1/3 of the disc space and a fluoroscopy. This patient was a 71-year-old male with severe low back pain. The L5-6 disc was hollowed out. Nucleus disappeared and instability was occurring. Resection of disc and endplate were done. A cage was sandwiched between double L-shaped retractor sliders. The cage was inserted along L-shaped retractor slider. PPS were inserted. Bone plantation was done. P-LIF relieved back pain. This patient was a 51-year-old man with continuous numbness on the posterolateral area of both sides with 200-meter intermittent claudication. Expandable spacer elevate can minimize insertion force, provide controlled dissection, and optimize endplate to endplate fit. The P-LIF mother bed can accommodate cages of various shape and is unlimited. P-LIF surgery time was 2.5 hours. Blood loss was 30 milliliter. Post-operative X-ray and MRI sagittal views showed good correction at L4-5, and the PPS system and cage were in a good position. 3 months later, the MRI axial view showed that the spinal canal was moderately expanded due to the extension of the redundant yellow ligament. 1 year later, the spinal canal was further expanded due to shrinkage of the hypertrophied yellow ligament. This female patient suffered from bilateral sciatica and 100-meter intermittent claudication. L4-5 showed lateral instability and disc space was narrow with disc herniation, right L5 root damage, and left extraforaminal disc herniation, left L4 root damage. Firstly, discectomy and endplate resection were performed from right wide disc space, and then left extraforaminal discectomy and endplate resection were done from left side. After PLIF, intermittent claudication and bilateral sciatica almost completely disappeared. This patient was a 71-year-old male. He had moderate back pain, 20 millimeter intermittent claudication, and severe right sciatica. CT showed right foraminal stenosis at L5S1 and spondylolysis. MRI showed also right L5 exiting load compressed. PLIF was performed. Right foraminotomy and insertion of the cage increased vertical distance of the foramen. This patient was a 46-year-old manual laborer with spondylolysis of L5 and spondylolisthesis at L5S1. At the L5S1 level, the iliac limits endoscope tilt. Therefore, it is not possible to completely create a mother bed only through one portal. Bilateral Kambin approaches can create a complete and wide mother bed. This patient is a 51-year-old male with spondylolisthesis. Expandable lumbar fusion device RISE was inserted into the intervertebral space at a contracted height. When it is expanded in the disc space, the implant can lift the upper and lower end plates to the appropriate height. Postoperative images show good correction. Conclusion of endoscopic fusion surgery. PLIF requires small incision at Kambin safety triangle and a continuous irrigation so clear vision. Smooth mother bed can be made under endoscope. Facet and muscle are preserved. Enough bone transplantation. Exiting root is protected by L retractor. Various type of cage can be inserted along L retract slider. No canal decompression in direct method. So no dural tear, no internal organ damage. Radiculopathy due to disc herniation or lateral recess stenosis can be directly decompressed. Thank you. The third Isthmus Asia Japan combined with the 13th Mid-Summit Forum will be held at IT Spine Hospital on 26th, 27th of next March 2021. Live surgery of PE-LIF will be performed. Welcome to Japan from beautiful Maiko-san.
Thank you. Thank you so much.
Thank you so much, Professor Fujimoto. It was an excellent presentation. No real comments on it. Fantastic, unbelievable, and I really appreciate all that you've been doing. And we have been also working in the same area, but I'm really appreciative of your work, sir. Thank you so much, sir.
Thank you.
I will now request Professor Koichi Sairio to please come on and start his presentation.
Okay. Can
We
you
can't see you, sir. We can hear you.
my slide?
Can you please start your...
Okay. Can you see my slides?
Yes.
No, I can't. We can't see your slides. Your camera is off.
Camera off? Okay.
Just check, please. We can hear you, but we can't see you, sir.
Okay.
Yeah, now we can see you. Welcome.
How about
Please
how
start
about
your
this?
sharing now.
Now share your slide.
Share? Okay, share.
There's a green button. Yes.
Yes, yes.
Okay.
Thank
Okay.
you.